Thank you. So hi, everybody. I'm Lindsay Sizemore, Viral Hepatitis Program Director for the Tennessee Department of Health, and I will be your facilitator for the session today. So today's agenda will include introductions and announcements, a didactic presentation on Hep C treatment evaluation, management, and post-treatment monitoring in children by Dr. Alfaro Cruz, and a pediatric case presentation, as well as Q&A and closing remarks. So first, some in-chat introductions, as well as some brief announcements. So before we get started, I would like everyone to take a second to introduce themselves in the chat. Please include your name, role, organization, and if this is your first echo session with us. I'll give everyone just a minute to do that. Okay, awesome. I'm seeing them come in. Great. Okay, next slide. Okay, I know last time I said was the last time. I lied. It's not. So we're doing this again. Hopefully this is the last time. But a few quick reminders I want to highlight that you may have seen when you joined the session. So I need everyone to take 2 minutes to complete the sign-in sheet. You can utilize the QR code pictured here on the left of the slide or the website, which Shamia will put in the chat. The sign-in sheet is required for our accrediting body, and it's the only proof we have of your attendance as far as they are concerned. If you do not complete the sign-in sheet, you will not be eligible for CE. And even if you don't want CE, we still need you to complete it. So I'm going to give everyone a minute to complete the sign-in sheet. And once you're done, please give me a thumbs up. Seeing a few, we're going to wait just a little longer. Okay, so an exciting update is that we will be changing our accrediting body from the ECHO Institute to the Southeast AIDS Education Training Center, hopefully by our next session. So more information regarding registration is forthcoming. Dr. Chastain, would you like to give your evaluation announcement?
Yeah, so hopefully this is also the one last time to speak about this specifically or separately. The Southeast AIDS Education Training Center is a HRSA-funded entity that allows people like me and Chloe Tipton to help support programs like this, as well as other educational programming related to medical care and technical assistance for people at risk for HIV or with HIV or comorbid conditions. The only way we are able to take credit for the work that we do in the educational space is to have a track record of the people that we touch and that we impact. So if you are willing to just continue burning through those computer keys and registering on different aspects, Mia just dropped a registration into the seatc.com profile. The great news is in the future, we'll be able to roll all of your attendance, continuing education credit, as well as this ask into one in the near future. So stay tuned.
Thanks, Dr. Chastain. Next slide, Heather. So as mentioned, everyone's encouraged to set up a profile now. The link is in the chat. It's also on the slide. There's also a QR code, so multiple ways that you can access this link. And then there's just a screenshot on the far right of what this will look like. Next slide. Okay, so please turn on your video and mute yourself unless speaking. So again, to clarify, please try to always have your video on so we don't feel like we're speaking to no one, but please mute yourself unless you are actually speaking. And please come off mute to ask any questions that you might have. Anastasia, has anyone joined by phone only?
Nope, not yet.
Great, thank you. Please never discuss PHI and please treat everyone with respect. And with that, I will turn it over to Dr. Alfaro Cruz for today's didactic presentation. Dr. Alfaro Cruz, please say next slide when you would like us to advance the slide for you.
Okay, thank you, Lindsay. Can you hear me well?
Yes, we can.
All right, perfect. Next slide, please. So today we're going to talk about the hepatitis C treatment monitoring and post-evaluation. I have no financial disclosures or conflicts of interest to report. Next slide, please. So why, we already talked in our past didactics about why hepatitis C is so important. just to kind of summarize, we know that there's about 150 million infected persons in the world. That from those 150 million infected persons, we know that 11 million are younger than 15 years of age, and that chronic hepatitis C infection can lead to severe liver disease and other complications that can end up in either mortality or liver transplantation. We know that the cost in the US, estimated yearly, it's between 230 and $300 million. But that is something that it's just money, right? The emotional burden is actually more difficult to estimate, especially in children and their families when they are affected. Next slide, please. So we discussed previously, what do we do with screening, right? And because so far our testing recommendations has changed, and we're working together with the Department of Health of Tennessee. We know that if a child now is needs to be screened because he was actually born to a mom that we know is infected with hepatitis C, ideally we need to obtain the first screening before 2 months of age or less than 18 months of age. And the test that we're going to use is hepatitis C virus RNA. Now, ideally, we want to take advantage of that kid when he comes to a well child, so we can identify those and monitor closely until we are able to treat them when they turn 3 years of age. What happens when that kid turns 18 months of age is we're going to get a hepatitis C virus antibody, and if positive, we're going to get a hepatitis C virus RNA, with the goal that we can identify these kids, catch them early, and then treat them early, actually, to prevent future complications from a chronic hepatitis C infection. Next slide, please. So we talked about once we identify that kid that tested positive for a hep C antibody, followed by an RNA testing, we talked that we would actually get a hepatitis C virus genotyping, something that we get more common in children than in adults. That liver biopsies are not indicated in children because most of them actually have not developed severe liver disease such as cirrhosis. Now, we do evaluate when we're planning on treatment for hepatitis B infection, HIV co-infection, and hepatitis A, because that can actually vary the treatment that we're going to provide as well as the care. Next slide, please. In the previous talks, we've also discussed about the different treatment options that we have on kids, especially now that we have direct antiretrovirals that are actually available starting age 3, and they can range between 8 weeks to 12 weeks of treatment, actually treating genotypes 1, 2, 3, 4, 5, 6. We have the first 2 options, which is glecaprevir and prevensivir, as well as sofosbuvir and velspavir. And then we have the other regimen that we have available. It's Harvoni, which actually treats genotypes 1, 4, 5, or 6. And the generic name is ledisavir and sofosbuvir. Next slide, please. So that's kind of a brief summary of what we know so far, right? But now that we have identified that kid, identified which medication we're going to use, then we have to have a goal. And that therapy goal will be to eradicate hep C virus RNA, which is predicted by attainment of the sustained virological response defined as undetectable RNA level 12 weeks following the completion of therapy. Pretty much what we want to make sure is that we cannot find any virus, any detectable RNA levels 12 weeks following that completion of therapy. Next slide, please. And so what is going to be important when we're monitoring treatment on the patient? One of the most things that we have identified that it's going to be so important in children is monitor adherence. Other ones, like the adverse effects that can happen from treatment medication, as well as monitor hypoglycemia, especially in those children that are taking diabetes medication, and monitor INR or coags of individuals that are taking anticoagulants or subtherapeutic anticoagulation. Now, if you ask me what are the 2 main things, it's going to be adherence and adverse effects. because those are the ones that tend to actually get us in trouble if kids are not being adherent. And I think we've discussed in the previous lectures about how to make sure that kid is taking the medication, especially in those that are younger. And we'll discuss a little bit more forward. Next slide, please. So this is a very, very similar imaging of what Dr. Chastain presented us last time. And this is kind of pretty much showing you that when you start treatment and when are you going to actually check for a sustained virological response. Now, usually, and we'll talk a little bit forward on the next slides, but you start treatment and you expect that within 4 weeks, you're gonna have a significant decrease of the RNA particles on the therapy. Now, once we check actually end treatment at 12 weeks, then the goal is actually to check 12 weeks after you have ended treatment to make sure that the virus it's undetectable. And if you see here, you follow up for 12 more weeks or look at the sustained virological response at the 24-week mark, and you expect that there's still going to be undetectable. So that is pretty much the same goal as we do in children as well as in adults. Next slide, please. Now, how do we monitor when we're doing treatment? So in children, you have at week 4, the optional that if you want to bring them to the clinic to check how they're doing, you can check a CBC, a creatinine level, liver enzymes, and total bilirubin. And if you have any concerns of adherence in that patient, you can actually check an HCV PCR RNA. Can we go back to the previous slide, Lindsay, please? In the previous slide, as you can see, we usually start treatment, and at that 4-week mark, you can see how the levels have significantly decreased to undetectable. So this can be actually a good marker to see if that patient is being adherent and actually touching bases and see what else can we do to improve adherence. Next slide, please. At the end of the treatment, it's optional to actually recheck a Hep C RNA if there has been concerns with adherence, especially because you would expect that, as we saw at week 4, there are undetectable levels. The same will be actually registered at the end of the treatment. And then finally, at 12 weeks after finishing treatment, all patients treated will need to get a Hep C RNA PCR as well as a hepatic function panel. As you can see, we usually don't repeat at 24 weeks after finishing treatment because we know that the levels will actually be undetectable. Next slide, please. Now, we do encourage, actually, and according to the Hepatitis C guidelines, we do encourage either clinic visits or telephone contact, at least during that first 4 weeks, to make sure that the patient is actually being adherent to the treatment, or if they have any questions or monitor for adverse events. Now, usually, I like to bring them at that 4-week mark because that's when we can actually get to see what's going on. How are they taking the medications? How are they feeling? Are they having any side effects from the medication? Are there any way that we can assist them in order to continue making sure that they're taking the treatment? And so nowadays, because we do have the telehealth option, this actually has been working great in aiding us or helping us to actually get to contact our patients and family members and say, how can we help you and how we're doing with the treatment? So in those places where you think, okay, we live in underserved areas, we cannot bring our patients that close because they live far away, telephone contact, telehealth options should always consider a good to go tool in order to help monitor adherence. Next slide, please. And so remember, and this is very similar to what we were talking last didactic about kind of what happens if when you check your liver enzymes, you're seeing changes of, for example, a more than 10 increased fold in ALT values at any time during the treatment. That should actually be a sign that you need to discontinue the medication, especially if there are symptoms or of liver inflammation or increased conjugated bili alkaline phosphatase or coagulation marker. an increase in ALT less than tenfold from the baseline, that it's accompanied by weakness, nausea, vomiting, jaundice, or significant increased levels of bilirubin, alkaline phosphatase, or INR, should also prompt the discontinuation of direct antiviral therapy. Now, in asymptomatic patients that have an increase less than tenfold from the baseline, they should be closely monitored with repeating testing at 2 weeks intervals. And if levels maintain persistently elevated, then you have to consider whether we need to discontinue therapy and monitor closely that patient. Next slide, please. Now, there are special considerations that we need to take into account when they are taking therapy, especially when we talked about adherence and we repeat a Hep C viral RNA at week 4. And remember, this does not accurately predict failure to achieve the systemic virulence response, but it can help us assess adherence and discuss new medications that have been started. For example, last time we talked about PPIs as well as antibiotics, especially like azithromycin, things that can actually mix with the medications that we're giving and affect how we are absorbing medication, or if it's having any medical interaction. Now, at that time, if you are not seeing significant decrease in the amount of viral levels, then you may consider actually bringing that patient in week 6 and repeat the HCV RNA PCR. Although I have to admit that there is no direct clinical data that actually says that checking at 6 weeks will make a difference. So, but it can be especially important in those who are you're thinking that are not being adherent to the treatment. Now, what happens if there is failure to achieve an SVR response? So retreatment, it's always going to be recommended. In children's, we do have more limitations about the treatment that we can give, but it's always going to be recommended to retreat that patient. Look at examine, kind of do a self-assessment with the patient to consider reasons why there was a failure in medication. And those can include adherence, medication interactions like use of antibiotics or PPIs, or was there a delay in receiving medication from the pharmacy? Was it not covered? So you have to do kind of a self-assessment with the patient and see what happened that led to that failure to achieve response. And you will have to, while you are planning to start retreatment, you have to assess the progression of disease. And you'll have to do it these every 6 months to 12 months while he's waiting for retreatment. Next slide, please. So then we need to move forward and think, okay, we talked about the special considerations. We talked about what to do when it has failed, that we know that retreatment is indicated. Now, what happened when that patient finished treatment, did show us a sustained virological response? And so for those cirrhotic patients, for those non-cirrhotic patients, recommend follow-up is the same as if they were never infected with Hep C. We'll talk about education soon, but you have to educate them that yes, they can get reinfected, but we don't have to follow them with any specific labs or imaging. They'll have to continue doing their well child, their physical examinations, but otherwise it will be like they were never infected with Hep C. Now, assessment for Hep C recurrence is recommended only if the patient develops unexplained hepatic dysfunction, or annual assessment if that patient has ongoing risk factors for Hep C infection. In those cases, the test that we always are going to get is a Hep C RNA test. We were never going to check with Hep C antibodies because we know that they're going to have Hep C antibody positive tests for the rest of their lives. So it's important to kind of assess those, especially when you have patients who are presenting with symptoms that you cannot explain why, and he had a previous infection with Hep C. Next slide, please. So in the patients where we actually have diagnosed them with cirrhosis, which in case of pediatric patients is not very common, but you do have to check for surveillance of hepatocellular carcinoma. Ultrasound or alpha fetoprotein could be some of the tests that you can follow up with then to make sure that cancer it's not actually something that is happening in these patients. Now, for cirrhotic patients, usually upper endoscopy surveillance is recommended for the concerns of varices that they can present. And you have also to assess for other causes of liver disease, especially in patients who develop persistent abnormal liver tests after achieving a sustained virological response. Remember, we have other diseases that can affect the liver as well. So in patients, you may think about Wilson's disease, alpha-1 antitrypsin, other type of viral infections. So those are things that you have to be aware, especially in patients who we consider were cured and start showing signs of liver disease as well. Next slide, please. Now, what do we do with counseling? So counseling is a very important part of what we do once we finish with treatment. We explain to the parents, or if they're a little bit older, we explain that the Hep C, the antibody will always be positive, no matter what. That the reinfection is possible. And that is one of the most important things that we talk to them, because they are so little, they're 3, 4, 5 years of age, or even when they're adolescent. We tell them that reinfection is possible and that this treatment actually does not prevent them from getting reinfected again. And that's something that we make emphasis about, because there is, and sometimes I've heard the patients say, oh, but because I'm treated, and if I have a baby, he won't have it. But I explain them that reinfection is possible, and that even though they're teenagers, when they get pregnant and they get reinfected, they can actually infect their child as well. And in case they are reinfected, Hep C RNA PCR will always be the test of choice, because their Hep C antibody will always be positive. So the PCR will be the best choice. Next slide, please. And so educate, educate, educate. And this is going to be something that it's always, you're going to see in my slides, because it makes such an important impact, not only the patients that we talk to, but the families as well. I've always mentioned that when we are diagnosing children, there is a lot of stigma around having that diagnosis, especially when they're going to kindergarten, to daycare, and to schools. And so my mission, as well as treat, it's educate, educate, and educate. So we teach them, we tell the parents that this is not something that is transmitted by casual contact, that children that are infected with Hep C did not pose a risk to other children and can participate in school, in sport, in athletic activities, and engage in all activities without restriction. The most common questions that I get asked is, can they go to a party? Can they sleep at a friend's house? Yes, yes, yes. There should be no limitations, no restrictions in what children do. And that when you're treating a child with Hep C, universal precautions should be followed at school and at home, as they will be with anything else. This is important because the family needs to be aware that this is not a reason to not say we're not getting treatment, because we are afraid about the stigmatization that comes with the diagnosis and treatment as well. So if we educate our parents, we're more likely to get the benefit of adherence, treatment, and eradication of Hep C. Next slide, please. Do we have any questions up to this point?
So we're echo pausing. Any questions from the participants? Before I ask the SMEs if we have any questions, Mia, I know we have a backup SME today. Would you like to introduce our backup SME?
Yes, so Dr. Allen was not able to be with us, but he did send one of his colleagues. So thank you so much. Is it Dr. Chotsky? Is that correct? I think you might still be on mute.
Sorry about that. Yes, that's correct.
We are so happy to have you with us. Do you want to introduce yourself for just a moment?
Sure. So my name is Sheena Chokshi. I am a pharmacist. I work with Dr. Allen. I'm one of his ambulatory care residents. And so I've spent a little bit of time with him working with hepatitis C patients in his clinic. And I'm really excited to be a part of this discussion today.
Thank you. So we will be so grateful for you as we ask those pharmacy related questions and continue on into our case. So Lindsay?
Great. So I'm echo pausing just one more time to see if there are any questions before we move into the case presentation.
I just put one in the chat, Lindsay. I'm wondering for Dr. O'Farrell-Cruz, what the biggest challenges you see with families regarding side effects and adherence issues.
So the most common side effect that I tend to see at the beginning of treatment, and that's usually the first 2 weeks, is that the patient will complain about nausea. And that is something that as they start taking more of the medication, the symptom goes away. Now, the main thing that we're noticing, it's adherence. Adherence is becoming a really a problem in children. One of it's because, well, it depends on a child. It doesn't depend completely on the child. It depends on the parents. And sometimes there's the mistake of like, oh, we forgot one day, but the next day we did, right? So what I'm looking more in the children that I'm treating, it's an adherence problem. And we'll talk a little bit about the case that is coming soon, but also on those children that are adolescents and are not children, that are between that 12 and 15 years of age, where they have a little bit more autonomy. And the parents say, oh, yes, I remind him to take him his medication, right? And so that is being a problem right now because we're talking about children. They may look bigger, they may act like they're bigger, but they are not. And so that is something that I'm always telling them. You have to make sure he's taking the medication. It's okay if you give him the responsibility of taking into account, taking ownership, but you have to look at that kid taking the medication. You have to set up alarms. You have to set up reminders because we are not playing here. It's not like, oh, I forgot to take a pill of Tylenol and that's it. So what I'm seeing more side effects, not really so much. So far, I haven't had to discontinue any treatment because of elevated ALT or weakness or any of the other major things that can actually make you discontinue treatment. Nausea, a little bit of epigastric pain are the most common side effects, and they usually go away within 2 weeks. But adherence is the main issue that we are fighting with. Not so much interesting in small children taking the medication. Since they actually created the little pellets that they can mix with applesauce, chocolate sauce, it's actually been easier for the kids, for the younger kids. But it's the older kids that are having more issues with adherence to this treatment.
Super helpful. Thank you. I actually spent the weekend with my nephew who is a teenager and knows everything about everything. So I completely could see how that could be an issue. Any other questions? Comments? Fun facts? Anything that anyone wants to say before we move on?
I was going to ask Dr. O'Farrell-Cruz a little bit about formulations, particularly with smaller children, as far as your experience regarding the adherence with the different formulations, whether that be with medications that have been crushed or sachet packets or other aspects, and that being how much of a barrier that's been for you in your practice beyond just the side effects.
So I think, to be honest, the pellets or the package that we can open up and mix it has been a truly life-changing for therapy. We, crush pills or try to have a kid swallow pills can actually be more difficult. But ever since they actually make that presentation where we can mix the pellets, mix it with anything, it's actually easier for children to do. I know adults, I know 18-year-olds that cannot swallow pills. And I had a case where I had a 16-year-old, I think it was, she could not swallow pills. We even had pharmacy kind of teach her how to swallow pills. It was not working. So that was in a special situation where we have to use the pellets. It was approved and it was life-changing because I think we have been able to make sure adherence is easy for those patients if we're able to actually get them to take the medication.
Super helpful. Thank you. Okay, last call. Questions, comments, anything else before we move on? I'm not seeing anything in the chat. Okay, so with that, we're going to jump into our pediatric case presentation for today, which will be presented by Laura Price. So Laura, please say next slide when you want us to advance the slides.
Okay, can you hear me?
Yes, we can.
So the following slides